we tend to hear, and often in HHS, we tend to focus on the public system, but we should remember that's about a third of the state. Of course, the governor is responsible for all of the states.
Right.
So while a lot of what we tend to talk about is this public mental health system, many of the times what I hear from the horseshoe from within the governor's office is, so like, what's the private sector doing here? And, I hear you talking about all the stuff you want to do on the first episode of Psychosis, but those are mostly 15 to 25-year-olds that are still on their parents' insurance. So
Okay.
why is that just a public mental health problem? Why aren't we talking about the role of the private sector and maybe even a public-private partnership? So there's a lot of interest in trying to think about that other side, which, hasn't really been so much in the conversation.
Okay. So one of the things that we wanted to start with was the idea of mental health services, oversight and accountability. And I believe we're going to kind of weave in your understanding and clarify any questions or topics that we start on about your the way you view the structure and function of the California public mental health system, the way that state oversight plays a role, given the county level system that we operate within. But more specifically, how do you view, since the MHSA became law and its overall public policy vision for the public mental health was about system transformation and recovery-oriented systems, what do you propose to do differently than what we're looking at right now, or where we're at?
Well, so the first part of that is like, how is the public mental health system doing in California? And it's impossible to answer because we've got, depending on how you count it, 56, 58, or 59 different systems.
Right.
And they're all doing different things. It's really a very fragmented and very distributed network.
Okay.
So, do we need to do anything technically? Are we having trouble picking this up?
No, you're good.
Okay, good. So that, I think, is a real challenge for the state. I don't know that there's another state, certainly not a state of this size, that has only county level leadership, where there's not a kind of state level leadership in terms of setting standards, setting goals, collecting data, creating a kind of coherence to what's provided either in the public or the private sector. So this is a pretty unusual situation. It's also
one of the things that clients really appreciate coming from other states to be advocates and clients in the California system is the way there's a recovery-oriented measure or goals for client-driven activity and client-driven practices.
So what I've learned so far, and I may have this wrong, so correct me if I'm wrong, but a lot depends on what county you land in.
Oh, okay.
Yes.
Yeah.
And for someone who's gets on the road in San Diego and wants to drive to Portland, they're going to go through many, many different mental health care systems in that journey. And if they get ill along the way and need care, the care they're going to get is going to depend largely on how far north they've gotten. And what's very clear is that some counties are doing spectacular stuff. Most counties are doing spectacular stuff, but no one is doing it all. Mm-hmm. And some counties are really struggling for whatever reason. So the recovery-oriented piece of this, which is links then to the MHSA and the interest in sort of shifting to that focus, the same thing would be true. I think you're going to find that Mental Health Services Act money is used very differently as you go across the counties, with a kind of different understanding of, does this need to be always balanced by Medi-Cal? Can it be used for things that are not going to be reimbursable through Medi-Cal? A whole bunch of questions that get answered in different ways in different counties.
Right.
So you have all of that. You have all of that with all the counties.
Right.
It is inextricably entwined with realignment dollars now and with your federal financial participation. So it would be very, I think, hard to dismantle or detangle it now, because now most of our MHSA dollars are leveraging funds in the counties.
Right.
1.6 billion, I understand.
what the counties want to use, and understandably want to use the money to be able to draw down federal dollars so they can basically double what they're investing. That makes a lot of sense, but that there are also constraints that come with that. So there are certain things that you can't use Medi-Cal money for. And sometimes those are things that are really going to be vital for people to be able to get to a job, get to take care of
the
family.
purpose of MHSA was.
So if we're looking to, we focus a lot on MHSA implementation and the goals that are produced for holistic treatment, peer services, and things of that sort. So can you give us a little bit about your background or how you view implementing recovery-oriented services in a system, or your experience in it in the past, or past work experience with it?
Yeah, this is a new area for me in terms of looking at how to create statewide implementation systems or even county-wide implementation systems. I don't come from that world, and I've been learning a lot about it. I think it is kind of fascinating that the way the MHSA was set up, it's actually pretty agnostic about what the actual goals were. So there's nothing set in stone within the act that I've been able to find that says this is what success looks like.
True.
This is how we define success. This is how we measure it.
Except it was built on a village. Don't forget that.
Yeah, so there's a lot of interest in those kinds of models, but there's nothing in the legislation, in the statute, that says this is what we'll measure. This is what we define as a minimal requirement for being able to produce outcomes that the taxpayers care about. This is what happens if you meet those requirements. This is what happens if you don't. Those are, there are different ways of doing this kind of work. MHSA was set up in a way that was a little bit, I would call it agnostic about outcomes. It was really much more focused on the process by which things get approved and providing some guidelines for how the money would be spent, 80%, 20%, 5%, and then other buckets for other pieces of it. So it was around and local control. So it was around financing and a local process that involves community engagement as well, with the idea that every county would create its own system for how they want to use the money.
Which would be culturally oriented to their region and their space and their consumers and clients and populations.
So the value of having this done at the county level is clear that that's where there's the deepest understanding of what the needs are. So that's, you want to have that kind of local touch so that people are focusing on the things that matter locally. The problem.
I'm sorry, a question that just came in was asking, what about the different needs and demographics of the various counties throughout California?
That's what I was about to say.
That was a good segue.
Yeah. So that the problem is that what gets developed and what's tested out often doesn't scale. So you'll have something, and I've spent much of the summer visiting counties and finding out what they're doing with their MHSA dollars and looking at some of the programs in places like San Bernardino, Shasta, Monterey, and Yolo, and other counties, and it's fascinating because these counties are doing spectacular stuff. I mean, it's creative, it's impactful, it's so inspiring to see this. But each county is doing something different, and that might be okay. That might be fine, except here's the exception: is that you want it to somehow cohere. You want to know.
And looking at mile markers or those that you can kind of look at progression throughout the years, things of that sort.
So you can imagine doing this in a different way. And I think the question's now in front of us. Should we, after 15 years, should we look at this and ask it to do something different? Or is this the time in which you call the question? This is really a question for you guys. I'd love to get some feedback about this, because we've begun here at the Steinberg Institute to sort of wrestle with this. We've been able to say, all right, this has done spectacular stuff. Of course, it's now $2.4 billion, about a fourth of the public mental health spend is tied up in the MHSA. Altogether, probably $20 billion over the last 14 years. And yet, during that time, for a lot of our problems have gotten worse, not better.
True.
Are we doing this the right way? Is there a better way to use these funds? Should we be rethinking this? And instead of doing 1,000 things in 58 different counties, do a few things, do them really well, and make sure that across the state, we're having the kind of impact for those people with the greatest needs.
So there's a similar policy opportunity in California with a local control funding formula that allows for local education agencies to handle how to address statewide goals or to reduce disparities among certain target populations. So that might be a similar model to look at as far as statewide goals that still have the local control aspect or a local taste or flavor to how they're addressed through the community needs.
That's a great description. I think you've just nailed kind of what the model would be, which is what the state can provide. It's a couple of things. I think the state can provide a definition of success. What is it that we're shooting for here? What are we trying to accomplish?
And can it be a recovery outcome, not just an alleviation of symptoms?
So that'll be part of the discussion. It's like, what are the, what are the measures of success and for whom? The other thing that the state can do is it can provide this support to help people reach those goals. And it can provide some systems for measurement so that we can monitor and know when people need more support to be able to reach the goal.
So do you mind if we touch on this a little bit? This is a material that I provided a little bit earlier. It's slides from our year 2 conference down in LA earlier in August. We had Dr. Mark Reagan's address the conference as our keynote speaker, and he was talking about milestones of recovery as a means of measurement for recovery-oriented systems. And so that would look at the sense of risk level, I believe, is what the primary categories is that they fall into, rather than necessarily seeing your doctor every month or things of that sort, which they all play into a certain level of interaction. How do you envision quality services or milestones of recovery as opportunities for measurement and that vary from what we currently have?
Yeah, these are tough questions. So figure out what to measure and how to do it well, and make sure you have a common system across the state, or across all these different demographics is a challenge. To do this, generally, you want to keep it simple, right? So one of the things one could measure is mortality. So we know there's about a 25-year gap in longevity. Can we close that gap for people with serious mental illness? We know that the rate of suicide in California is about 10.4 or 10.1 per 100,000. Depending where you are in the state, it's as high as 20 in other parts of the state. Can we bring that down by, you can figure out what the right approach would be, is it 30%, 40%? We can look at how many kids with serious emotional disturbance are graduating from high school. And this is the single largest source of disability that keeps kids from graduating. That's something we ought to be able to have an impact on. You can look at employment. You can look at housing. There's, these are things that are really important to measure. We're not doing that now. And to be fair, I think in spite of all the efforts, all the money, and all the talent that we have here, the rate of homelessness for people with serious mental illness has gone up. The rate of incarceration has gone up. The rate of employment has not improved. And so we've got some challenges. I think part of the way you address those challenges is you start by measuring, so you know when you're succeeding and when you're not. There's an old saying where I come from. It says that in the absence of feedback, your confidence grows much faster than your accuracy. And that tends to be kind of the problem we're facing. Sorry.
No, I just wanted to say that I think, what you described is sort of the state of where we are at with MHSA now. I think that we got here not necessarily by accident. I think we knew all along we needed outcomes, but a lot of people weren't talking about these kind of things where we keep talking about recovery outcomes, because that was really what the MHSA was supposed to bring about in California. And that's why we modeled it after programs like the AB 23-4 and the Village. And I think what happened, it was sort of this perfect storm. You lost state MH that provided oversight. I mean, the whole department went away. The whole Department of Mental Health. So they provided oversight, and a lot of this guidance, they went away. New people came into the counties, and they didn't know about recovery, and they started implementing things that they thought were great. And so I guess for us, that we want to make sure that no matter what happens in the future, we don't lose sight of the very things that are critically important to our mental health system, and that is to foster this idea of recovery, and not so much as alleviating hospital stays and alleviating symptoms, but helping us find our lives back again, and for our own self-defined recovery goals. And that may be a little bit different from the things that you described. It may not be staying out of the hospital or alleviating all our symptoms, but it may be finding a job, or it may be building relationships again, or not isolating anymore.
And that was
and the more these type of recovery instruments, there's a whole body of literature on it, and you're a scientist, you know better than I do, but that we're just not utilizing to our best advantage here in California. So we've been a little bit frustrated with that piece of the implementation of MHSA, because that was really what it was for. And the statute is very clear that it should be client directed and recovery oriented. Those things are very clear. What that looks like to different people isn't so clear. But I think our standards really, we need to be very clear in those type of standards.
Right. I want to separate out what are basically ways of talking about the process, having community engagement, client-oriented, recovery-oriented.
That's the services more than just the process.
But it's the way so for us right now, we're at that stage where we're saying, we're trying to define the what, not so much the how. And the what is to say, what do we want Prop 63 to accomplish? What is it that we want to be able to say within the next 2 to 3 years that this funding is able to do? And I don't think we fully answered that question. I think that's a collective question that a lot of people need to be thinking about, but we do need to answer it. We do need,
I would say.
I
to
appreciate
define
that. May I just add one thing? I think that when we identify the what we are hearing consistently from stakeholders and throughout the state is that they want to have a voice in shaping the systems and the services. And that was one thing that was so innovative about Proposition 63, the MHSA, is that it called for unprecedented stakeholder feedback, not just on program design, but ongoing evaluations and influencing how the budgets will look. And so where are the conversations going right now, and how do you see utilizing meaningful stakeholder involvement if we are going to reshape or propose reshaping the Mental Health Services Act as it's written today?
It's the right question. Again, for me, that is still in the area of process. I don't think that's an end in itself. I would be personally disappointed if the success of this was defined by how much stakeholders were involved. I think that's an important part of it. That's how you get to success. But to me, what I would love to see is that we could say, on the basis of having these funds, we've reduced incarceration, we've reduced homelessness, we've reduced mortality. We've got a society in which people with serious mental illness can do better, can get a life, can get on with their lives. And we're not doing that. I mean, I think we've done pretty well on the very thing you described.
We should be talking to the people who have recovered then. They are the people that are most important to this conversation.
They are important to the conversation, but we also have to hear from people who haven't, and for people who are really struggling, and they feel that, many people feel this has not served their needs.
Oh yeah.
The funds are being used for lots of things that are not solving the problems that a lot of taxpayers who are contributing to this feel are the most urgent. And what are those things?
Well, they didn't spend the money. I mean, honestly, Dr. Insel, a lot of counties sat on money. That Los Angeles County, we have some great colleagues down there, they sat on $1 billion.
Well,
Sacramento County.
In all due respect, Susan, if you look on the transparency suite, it looks like it's $1 billion that have been unspent. Most of that's encumbered, so it's actually, it's already committed.
If you look at the county budgets, it's in a line item that says unspent. It's not budgeted in the county budgets. I looked, Dr. Insel.
Well, I've sat down with LA County in this
They'll
room,
tell you all kinds
and
of
we've gone
things.
line by line through their budget, and I can tell you the number's not 900 million. It's
No,
less
no,
than
I know
that.
they're getting better because of this push, because of the California auditor. But just can you imagine if we really spent that money during the time when we could have, how much better we could have done for the client?
But just to be clear, and because I hear this a lot, that people say the MHSA, there's too much money because people aren't spending it. The fact is, probably half the
Most
counties
of the
have.
counties spent it,
Yeah, probably half the counties have no reserve. They
Right.
actually
No,
don't
I
even have the
absolutely agree.
legislatively required
I agree.
reserve, and they're running on empty. So.
But the very big ones,
Yes,
What is
so
effective?
LA has some additional funding, but the actual number is probably closer to 100 million, not a billion. And even that 100 million should probably, they'll be able to catch up on that fairly soon. They've got 10 million people in that county. They've got a lot of needs. And so there's no shortage of opportunity there.
So we are hearing some feedback around the comment around hearing from those who are not mentally challenged. We need to hear from those who consistently get ignored, those affected by the system. And it goes on, but I think that there is, consistent, we've done quite an extensive data collection, and there is consistent theme across the state that individuals with lived experience who are, according to MHSA, supposed to be driving the process and aren't having their voices heard in a meaningful way throughout the system. And so how can we ensure that we can incorporate those voices to, promote individuals' recovery?
Yeah, so that's part of what MHSA does, right? Excuse me. I mean, part of what it's set up to do is to bring in that kind of involvement.
So while we're talking about possible MHSA, in the September 5th listening session with the LGBTQ contracts, you made mention of an MHSA reform or change or meetings that are happening in this room about possible amendments or things that might be happening. Based on your knowledge and understanding of the initiative, what impacts would it have on the MHSA as it's currently written?
Yeah, so it's still a very early process. But we've heard from some of the county behavioral health directors and from a variety of stakeholders, particularly people in the criminal justice system, from people who work with children, child welfare groups, a range of different advocates about what they would want to see, what's working, what isn't. And we're kind of at that stage of just kind of collecting the information. I've been trying to capture a bit of that by visiting some of the counties that both large and small and rural and urban. I think what I'm going to kind of summarize where I would imagine this is going, but this is just a projection because it's still an early process. We are unlikely to change the tax. Okay. I don't think we're going to be asking for more money or less money. I think we are interested in creating some outcomes for specific populations, and those populations are people who are incarcerated with serious mental illness, people who are homeless with serious mental illness, and kids at risk, where they're not getting the kind of wraparound services that could mitigate their disability later. So for those three populations, I would imagine we're going to try to craft what are the measures of success we'd like to see. What's the North Star that we want counties to focus on? I think it's also likely that we will find a way to give counties more flexibility. One of the things that we hear a lot is that the way this is set up is actually for them rather rigid. First of all, the kinds of cost accounting they need to do. It's a huge amount of documentation. And often it's really demoralizing to people who work within the county structure. So we'd like to give them some flexibility at the same time that we give them some accountability around goals. And we'd like to find a way to be able to measure as we go, so we can help counties to be able to monitor what they're doing and to know when they're successful, when they're not. There are other questions I think we should be asking about the innovation fund. Is that working in a way that has really had an impact after 14 years? We ought to ask about whether the Oversight and Accountability Commission has the kind of oversight and accountability that you'd want.
Right.
Right now, they have oversight over the innovation fund, but not much else. Is that really what you want for this large investment?
So is there an opportunity to meet these goals for target populations within the county behavioral systems and county operated services, those that might be peer run, those that might be community-based oriented or community-based organizations and things of that sort? Sure. Is that where you see money trickling down to, or?
I haven't thought of where the money is ultimately going to go.
Good.
But I think it will be, since right now this is going through the county behavioral health offices, and in some cases that gets contracted out. In a couple of counties, they do most of the work in-house. But that's probably still going to be the locus of this. And those offices are going to have to figure out how best to serve the needs for those three populations. There are other questions that have come up, like should this be regionalized in some way? Right. Should there be a carve-in so that it's within the managed care services? All those things have been discussed.
I think a recurring question that keeps coming up is how will clients be incorporated in these preliminary discussions?
They're already starting to be, but these are really preliminary. So, and ultimately, if we're going to change the act in any substantive way in terms of how, if in any way, for instance, changes the financial arrangement, this will have to go back to the voters. So there'll be a long conversation about that process.
So also on September 5th, you mentioned a possible stakeholder opportunity to get engaged. And that was one of the reasons why I was excited to present this opportunity with you, is to allow listeners to understand how that process might roll out, when it might roll out. Is there something that we can look for in December, January, any tangible elements that we can look at?
It'll probably have to be before then.
Or organizations that might be operating it.
Yeah, so the Steinberg Institute would probably be the place to do this, and we haven't quite figured out yet what we need a sort of straw man document. We need something to be able to share before we can begin to ask for input. I'm not interested in having 100 meetings before we have the first document, and then another 100 meetings to be able to go through that. So I'd much rather put something out for people to look at and to chew on.
Well, we're available to help you with that straw man document.
And just, there really is a very long history of consumer involvement in the public mental health system in California. The mantra really is nothing about us without us. When you look at the recovery literature and you see the people who have gotten better and the systems that are recovery oriented, they're the ones who have consumer involvement at every level.
Right. And
they don't, kind of cherry pick that. They make sure that they're there.
So we should also clarify, there are two processes going on, right? We were talking about the MHSA.
Yeah.
There's another process that has to do with everything else.
Right.
So the waivers and all of that.
Mm-hmm.
And in addition to the waiver process, there's a conversation going on through the California Health and Human Services Agency about should we be looking at the entire system, which MHSA is a little piece. And there very well may be there as well an even more important stakeholder involvement opportunity, where there would be a set of meetings that will bring in a whole range of stakeholders. And in this, as you all know, there are almost an infinite number of stakeholders in the behavioral health space. There are people who have very different perspectives on this.
Correct.
So what I've just described is really three different things. So which is a lot. I mean, we've got the MHSA process, we've got the HHS process, and we've got the waiver process. And, maybe that's too many, and maybe at some point we should find a way to consolidate. But they're all at this very early stage. I think the waiver has the stakeholder group that's already been brought together once. I think there's a second meeting coming up.
At the end of the month, the 29th.
And then this HHS process, if they decide to go forward, there'll be yet another opportunity there. And then we've got the much smaller effort, which is going through this institute, which is still pretty early on.
Okay, thank you. So hypothetically, if we're looking at target groups for MHSA priorities, has there been any gap analysis or an idea that might look at how, if money shifted, what might fall through the cracks, or what would be the losses in the way that we're looking at the system currently operating and possibly reoriented?
That may turn out to be a county by county issue.
Mm-hmm.
I suspect that. I think the way this will play out is that the counties will still be very much the locus of governance here. Whether that will be 58 counties or whether they could create regional efforts, and maybe it'll be, I don't know what the number is, maybe there'll be 20 or 30 or 12, whatever that might look like.
Right.
You can imagine.
And that would be more regional to a certain degree.
I mean, that's the way we do the managed care contracts.
And the continuum of care.
Right.
Mm-hmm.
So, not quite clear what the mechanism will be, but at that point, I think the question you ask is the right one, which is if we're going to be changing things, we've got to make sure we don't break something as we're
Right.
using now. And so we're very conscious of kind of unintended consequences and thinking through. Let's say, for instance, we did away with the 80-20-5% breakdown that we've got currently for how the money gets spent. Is that inviting problems that we might not know how to deal with? And, but does that mean suddenly there'll be less money going into early intervention and prevention? Is that going to be an issue for us? So I think this is the time to start having those conversations and to think through what might be the best way to prevent an unintended consequence like that.
Right.
Yeah, it would be really interesting if managed care companies got MHSA funds, because they're all for profit, most of them, the majority. So, there's just a lot to think about.
We have, it's a really complicated system.
Yeah, there's a mix of nonprofit, county-oriented, and for-profit. One of the things that you touched on was possibly a regional approach, how counties could cooperate a little bit better. Is there an idea about technical assistance or facilitating communication between counties to help them operationalize successes and the moments of success that you've seen already that might move forward in a stronger way regionally?
That's not so new. I mean, that's really what was the concept behind the Joint Powers Authority at CalMesa, was that we were going to create a platform where counties could easily share and work together. It's been difficult, I think, for in some areas. There have been some successes.
You lose some transparency when you have the joint powers. You lose some of the local control, and you lose a little bit of the transparency. It's a little harder to get public records requests out of them.
These are always trade-offs, and I think
from experience.
The one thing that I think we're struggling with here is, on the one hand, the system we have now has some wonderful successes.
Absolutely.
But when you step back and you look at where are we as a state, it's not working. I think we've got to admit at some point that over the last 15 years, in spite of all of the efforts and all of the money, on almost all of the metrics that we would use to look at outcomes, things have gotten worse, not better.
So that's why I just say you got to listen to the advocates. That's all I have to say, Dr. Insel, because we told them back then if they did it this way and they put those recovery outcomes, things would be different. I mean, sometimes it just feels like Groundhog Day. Like it just, I've been doing it for 22 years.
That we also want to address, or at least touch on, is when we're looking at California and the outcomes that we've seen over the last 15 years, income inequality has gotten worse, and discrimination has also increased across the nation as a whole, as far as those minority discriminated communities, how do we operate with those higher disparity rates in mental health system or in mental health client populations that are minority oppression and that deal with minority oppression and the higher representation in low socioeconomic families? Do we approach it after they come to us with a crisis, or is there a way that mental health can apply for community mental health or community-oriented systems that aim towards helping people in their community kind of reintegrate or reconnect with those that can help them?
Yeah, I just came back from Trieste, which is doing a lot of just this kind of work. There were 35 people from LA County that went last week to see how that's working there. It's a different, it's not clear how much of that can translate to California. They don't have a problem with substance abuse like we do. They don't have homelessness. They certainly don't have the incarceration of people with serious mental illness. It's a different set of issues. And Trieste is not California in terms of the culture even. I mean, you've got families, you've got a social safety net, you've got a whole bunch of things that are missing here. Nevertheless, it was fascinating to see what can be done in the community. One of the things that was so striking, it's a sort of moments of shock, was when there was a visit with the crisis team, and the crisis team said, well, the first thing we do is we contact family and bring the family in. And of course, the people from LA said, we can't do that. And they looked at us like we were from another planet. They said, what do you mean you can't bring in that? How could you possibly provide care without including the family? That's the beginning of how we provide care here. How do you do crisis intervention without a family involved?
I would also take it one step farther back, that we don't have crisis intervention systems.
We
have emergency intervention systems. So
which is a very different
where we also need to start.
Yeah, and that was one of the beautiful things to see, that they had this 24/7 team made up of a nurse, a peer, and a social worker who are available around the clock and who go to people's homes. And a lot of the work is done in homes, even if it means staying 5, 6, 7 hours to see people through. Now, it's a smaller community. There's just a lot of differences, but it shows that this can be done. And when it is done well, the results are pretty good. And so I think we ought to be looking at what those kinds of opportunities will be. And to answer your question about, do you get involved with the social determinants? Can you move upstream? Can you create the kind of social safety net and the sense of connection that's missing? Sure. I mean, how else do you do this? I was at a meeting on the end of last week where somebody presented data on suicide in veterans. We have 20 veterans a day who kill themselves, and we have about I don't know, the number of attempts is probably about 10 times that, or actually probably 20 times that on any given day. What you got is a problem where people come in having made an attempt, and we don't know who we need to be most concerned about. We know that 15% of those people will be dead in a year from suicide, or from accidents, but we don't know who those 15% are going to be. So a very large study was done to try to understand what are the predictors of who will die in a year. And the things that were obvious, like people looked at diagnosis, the treatment they were receiving, gun ownership. You could kind of imagine. I think each of us would have 10 things we look at. What was the number one predictor of mortality? The employment rate in their zip code.
Interesting.
So to your point, we have to be thinking broadly.
Yeah.
It's not enough to be thinking about the dose of the medication somebody's
getting. So the last element, we have about 10 to 15 minutes before we wrap up. We also want, NorCal MHA is also a provider for peer training systems, or systems for peer training and peer employment training. With SB 10 at the governor's desk, how do you view that certified peer support specialists can be incorporated into the system that we operate with now, or maybe a coordinated care system? Are there roles for peers to play in these systems that operate currently and moving forward?
they're already there. I mean, they're a vital part of this. For me, the number one issue besides the fragmentation is the workforce.
Yeah.
And you could say, well, we'll hire and train, or we'll train more psychiatrists, social workers, psychologists. It's not clear that that's the answer right now. That's part of the answer, but one of the best ways to think about creating a workforce that actually has the cultural competence and has the trust and has the access that we need is to go with people who have lived experience and who are committed to doing this. By the way, it can be helpful for them as well.
Yeah.
So it's, it's 48 states have gone through this. California,
Right.
I think, what is it? South Dakota is the other
Yeah.
one. I don't know if the governor's going to sign this or not. If he doesn't sign it, it's probably because there are going to be some financial issues that haven't been worked out completely. And also because, to be frank, the governor's looking at 36 mental health care bills without, without a strategy. Because no one had sat down to say 9 months ago, this is what we're trying to do on behavioral health. This is the blueprint. This is how it all adds up. And instead, we have lots and lots of activity and lots of one-off bills. So I think we do need some time to sit down and say, this is the blueprint. This is what we're trying to accomplish here statewide. And this is the legislation we need to make that happen. And this is the funding we need to make that happen. So I'm not sure what's going to happen with SB 10, but if it does not get signed, I suspect it will come back in some other form to ensure that there is some certification for peer support. But I haven't heard anybody complain about peer support as an opportunity. Right. The concern is thinking through the funding of it, which, by the way, is probably, it's, to speak crassly about this, it's one of the best deals financially in terms of building the workforce. So
sure. One of the things, I guess, to tie it back into one of the earlier comments that we had was the partnership between public and private entities or mental health services. How do we increase peer employment in private entities and private services? Is it the baseline of certification that gives them those credentials, or is there other ways to encourage or incentivize peer employment to drop down the high unemployment rate of consumers?
I don't know the answer. I'd like to.
In our Kaiser program, we are using peers. We have 6 peers working.
So they didn't need to be certified.
No, and now we have since got them certified through our national.
There is a national advanced peer certification that they are certified.
And so, but when they started, they were not. They've been trained through our WISE program, through an OSHPD grant that we have. But we have been very successful. I mean, Kaiser expanded that program because of the success of it, and has reportedly, saved over $1 million the first year that they piloted it. So I think that there was a great deal of support for that program. Yeah, but that was in the first 9 months. Yeah. So it was quite remarkable. So I see that the private sector is starting to respond and to do more. I think Optum is a big provider. Not so much here in California, but other places in the country and in Florida that is using peers quite regularly. So I think the move is in that direction, but we certainly would always like to see it go faster, and we always worry about peers making a living wage. I think that's always another issue that we try to advocate for, because it's great to give them jobs, but they need to be a living wage. So there's just a lot of complexity to all of that as well. But I do think that the private sector, when they can see that they can get positive outcomes and reduce a lot of the recidivism rates, that they're big fans of peer support.
Which were part of the statistical outcomes that pushed for the AB 2034 programs and recovery-oriented goals that were targeted, and the statistical numbers that we provided in this material as well, that you'll have an opportunity to look at. We have about 5 minutes, if you don't mind. Do we have one last question from the audience that you might poll?
Lots of comments.
Lots of
I'm
comments?
trying to find you, trying to weed through all the comments.
Sure.
I mean, there was a very broad one for you. It says, Dr. Insel is the top advisor to the governor on mental health. What would you recommend, or what are your plans for the next quarter?
Quarter.
1
You got
year.
3 months to make something happen.
2 years.
Well, but actually, this is a critical quarter because he's going to be putting together his budget.
Yep.
And one of the things that I think is going to be really important to do over the next couple of months is to take this broad view with the waiver, the reprocurement of managed care contracts, the possibility of a change in Mental Health Services Act, to put all that together as a plan. So we have a blueprint. I think and we should have a blueprint I think we need to have it by the time the next legislative session begins. And then what we ought to be thinking, or at least let's say by the end of the calendar year. And then we need to have those budget items that are going to be important to put forward. So for me, I mean, what I would recommend, besides changing those different components, I think we need a really fresh look at workforce and ask what's the workforce we need in California, both in the rural counties and urban counties. Like, what's that mix? Are peers an important part of it? You bet. Peers are going to be a part of it. They're not the whole answer, but they're part of it. We need lots of other kinds of people. We need people with some very specific skills that we're missing now. So if we want to move upstream and ensure that every young person who has a first episode of psychosis doesn't have a second episode, we've got to have people trained in this whole model of coordinated specialty care.
Or a plan for their second episode.
Right.
That being, having something to respond to or work with.
Exactly.
This question comes from a client leader in the southern region. It says, what is your background in the recovery model, or your familiarity with the recovery model? And wants to know if you're aware of the struggle for parity, living wages, workforce integration shortfalls, and everything civil rights related to, somebody just popped in.
I think we're gonna have to cut it a little bit. With respect to Dr. Insel's busy schedule, we'll wrap up at this time. We hope to get an opportunity to work with you on further stakeholder involvement and things of that sort.
We need you.
As client-driven activities and things of that sort, we're really trying to represent a voice at the state level and among the conversations that are happening. So thank you for working with us, and thank you for the opportunity to speak with us.
It was a real pleasure that we could do this. And this is just the beginning of a conversation. So we look forward to getting lots of input. We want to make sure we get this right. And as you've all said, we're not going to get this right unless we have the right people involved.
We need to work together. Sure.
We appreciate that. Thank you.
Thank you very much, Dr. Insel.